Welcome to Meaningful Use and the Patient-Centered Medical. Welcome to San Diego. No, welcome to Meaningful Use and the Patient-Centered Medical Home. So I am pleased to introduce a dear friend, Anna Gard, who's a certified family nurse practitioner and has been in clinical practice for 17 years. Hard to believe, 17 years. She started when she was 6. Exactly. She is a team clinician for the Ginny Coombs Children's Health Center of VNA Community Services, a Level 3 NCQA PCMH Nurse Managed Safety Net Healthcare Center. So I am hoping that by the end of today we'll understand what all of those letters mean. That's our goal. And she works as the Health Disparities Consultant for the Association for Clinicians for the Underserved, providing technical assistance to special populations, including the National Center for Health and Public Housing and the National Healthcare for the Homeless Council. Her key areas of focus are the intersections of health disparities, quality improvement performance, patient-centered medical homes, chronic care management, and meaningful use of health IT and safety net populations. So we have a presentation, we have an opportunity to ask some questions, and she has some really great interactive stuff for us to do. So the presentation first, and then she'll take questions at the end of that. Groovy? Okay. Here we go. Here's Anna.
Okay, I hate this room because I feel like I'm so far away. I'm much better if I walk around, but they're recording, so I need to stay close to the microphone. And so David nicely introduced me, which said a lot of words, but what I want to talk to you today about really falls nicely with the theme of this conference, which is Keys to Health Center Success. And that is developing a patient-centered medical home in your health centers and using technology, health information technology, in a meaningful way to support your patient care. And so that's what all those fancy words meant, and we're going to talk a little bit more about what the patient-centered medical home is and what meaningful use of health information technology is. But I want to start with a question that typically we always used to think about as patients came into our exam room is you'd sit down and say, well, what's the matter with you? And when we think about patient-centered care, we think about reframing that question from what is the matter with you to what matters to you. And that's putting the patient in the center, because the patients are really a valuable resource in really successful health care. And by asking them what is most important to you, it can really help to define the way we want to provide care for them, and helps prioritize what is the most meaningful approach to care for them. So as we move the focus from what's the matter to you to what matters to you, we really want to engage the patient. We want to consider what their family values are, what their needs are. We want to include them in decision making, in problem solving, in discussion of health behaviors. That's what we call shared decision making. It's no longer that I, as a healthcare provider, tell you that you have high blood pressure and you need to be on a low salt diet and you need to take this blood pressure medication, but it's talking to you about what matters to you. It means you may say to me, I want to feel healthy enough to spend time with my grandchildren. We reframe the discussion so we can figure out a way to keep your blood pressure controlled so you feel well enough to spend time with your grandchildren. There we go. So this is just a funny little, well, I'm having some technical difficulties here. Okay. This is just a funny little cartoon that says that I don't know how to tell you this, but it looks like you have a brain the size of a walnut. And that is the patient saying that to the physician, because the patient is the expert about his or herself, right? I am the expert about me. And so when we talk about the patient-centered medical home, we're talking about putting the patient in the center. They are the expert. So HRSA has a patient-centered medical home initiative, and they're really promoting that their grantees, so their health centers that are receiving 330 funding, apply for patient-centered medical home recognition. And HRSA will cover the costs for all the survey tools and the recognition fees. HRSA will provide patient-centered medical home training and also a mentoring program. There are several different organizations that have patient-centered medical home recognition programs. I've listed 3 of them. The Accreditation Association for Ambulatory Health Care is one that is an on-site recognition program, and it's in addition to the ambulatory health care accreditation. It's an add-on program. The Joint Commission is another medical home recognition program, and this program is really excellent in evaluating fundamentals of clinical quality, things like accuracy of lab testing, infection control in your health centers, patient safety, clinical competence, and robust performance measurement. The NCQA, the National Centers for Quality Assurance, has a patient-centered medical home recognition program, and this concentrates more on 6 standards: access to care, patient-centered care, care coordination, and population health management. It's very useful to follow this recognition program when you evaluate the processes of how you schedule your appointments, how you provide access to your patients, how you triage, what is the general workflow of your organization. And it is very closely aligned with the Meaningful Use of Electronic Medical Records incentive program out of CMS. So often people choose to go for NCQA because at the same time they're adopting electronic medical records and they're attesting for meaningful use incentives. And so we see that the 2011 NCQA standards are very closely aligned with the meaningful use. It is the most widely adopted model, and there are 292 FQHCs recognized throughout the HRSA initiative that have NCQA patient-centered medical home status. For more resources, there is a patient-centered medical home resource catalog that we have put together and should be on the National Center for Health and Public Housing website, and that will give you the different comparisons of the different organizations, so you can go to that website and to the resource catalog to get more details on that. But I'm going to talk a little bit more specifically about NCQA, patient-centered medical home recognition, because I was tasked in this workshop to cover both patient-centered medical home and meaningful use. And so that's a lot to cover in a short amount of time, and I really can only do a broad brushed overview. So I'm going to focus on NCQA because I'm going to show you how it really aligns with meaningful use. So the NCQA has 6 standards, and you see them listed in the bubble here. The model, the number 1 standard is access. And when we talk about access, that means not only is your clinic hours available is there someone available 24/7 to meet your patient's needs? Now that doesn't mean that your health center is open 24/7, but there is a healthcare provider on call, or there's an on-call service for emergency phone calls. Do you have evening and Saturday appointments or Sunday appointments available for those who are in your health center who are working and can't get there during the day? Do you have open access scheduling so it's not difficult for your patients to come in and be seen? What is your appointment availability? Do you have access when we talk about, do you provide services in a language that your patients speak? So if you have a large Spanish-speaking population, are your providers and your nurses and your medical assistants and your outreach workers fluent in Spanish? Or have you hired a certified medical interpreter, or at least have access to a language line so that your patients can use the language line while they're in their appointment? The other thing we'd like to talk about with access is, do they have an assigned healthcare team, an assigned primary provider, that every time they come to the health center, they're not seeing a different doctor or nurse practitioner or physician assistant, that for the most part they're seeing the same provider, so that they develop a relationship, and so that that patient and what matters to them is known to their provider. The next standard is population management, and that talks about, does your health center have registries so that they can identify their population of patients that have diabetes, or they can identify their patient population who has asthma or heart failure, so that they can begin to target specific resources. So they may decide that they have a very large diabetes panel on their registry, and that they may want to develop group diabetes visits. And one of the earlier sessions today was about group diabetes visits. So do you have the ability in your organization to capture groups and populations of your patients? Can you identify what group of your patient population has not had their flu vaccine yet? Can you identify what group of your patient population hasn't had their Pneumovax vaccine yet, so that you can call them in to bring them in? It's also a matter of, when you talk about population management, is, are you collecting demographics? Do you know, and this should be no surprise for 330H grantees, because they have to collect certain demographics, but do you know your ethnicity and racial, are you collecting racial data and ethnic data and location and address? Are you collecting smoking status? So these are all very important things. Are you able in your system to create lists? So lists of problems. How many patients in your population are smokers? Are you able to create lists of allergies and medications? The next piece is plan and manage care, and that you'll hear a lot about, because the big buzz now is talking about care coordination and care management. And in the patient-centered medical home, as we move towards changing the provision of care from the provider to the patient to team-based care, where you have a whole team. You have your nurse, your outreach worker, your social worker, your physician assistant or PA or MD who are providing your care. You want to be able to identify who are your high-risk patients, your patients who have multiple ER visits in the last 6 months, who have multiple chronic comorbidities, so, high blood pressure, diabetes, heart failure. Can you identify those patients so that you can target more resources towards those patients, so you can assign a nurse care manager towards those patients? Are you using evidence-based guidelines in your practice, and how do you do that? Do you have them integrated into your electronic health record through clinical decision support? And are you able to do medication management? So for example, if you have a drug recall, so a pharmaceutical company has to pull a drug off the market, are you able to easily identify all the patients in your practice who are on a certain medication? Now, in the paper chart world, that is very difficult if you have thousands and thousands of charts to remember. So, do you have a system where you've are able to identify patients on certain medications? And we'll talk about how electronic medical records and health information technology can help support these processes. Self-care and community resources are patient education. Are you using education that's in a language and a low health literacy level that your patients understand? Are you engaging them in their self-care plan? And patient tracking, as I talked about, can you identify your patients who haven't had their flu shot yet? How are you exchanging information between specialists, between emergency departments, between hospitalizations? Are you having any health information exchange? And how are you managing transitions of care? How do you know when you had a patient who has been discharged from the hospital? How do you know to contact them and bring them back into the office so you can see them for follow-up? This is a very important component in care management now, because Medicare is going to get penalized for patients who are readmitted to the hospital within 30 days with the same problem. So care transitions are becoming a a big emphasis in terms of developing a patient-centered medical home where you know where your patients are, that they've been to the emergency room, that you need to call them to bring them back in. Do you have a policy that says a patient post-hospitalization discharge must have an appointment in your office within 72 hours? So these are the things you need to start thinking about as you're moving towards a medical home status. And what kind of quality improvement measures have you instituted in your organization? Do you do patient surveys? Do you know, are your patients happy in the practice? Are they satisfied? Do you have a patient on your board to tell you, what matters to them, what matters to their community, what matters to the public housing community that they live in? So when we think about providing health care, if you look at this slide here, gosh, these screens are so far away, huh? If you look, yeah, and the slides will be available to everyone. If you look, the patient is in the center, kind of like the hub of a wheel. And if you look at all the different providers, and this can be just in your health center, that touch a patient and create data, right? So the nurse, the patient care partner, who might be the person who assists with translation or transportation or appointments, or they may do all the referrals. The pharmacy, if you have an in-house pharmacy, the pharmacist touches the patient. If you have a nutritionist or dietitian who does counseling, any kind of specialist that they may see, maybe you have a podiatrist or a cardiologist who comes into your health center and sees patients, any of the behavioral health specialists, your lab, your care manager, your medical assistant, your healthcare provider, and then they generate all this data. How do we know that all these different people have access to all of that data and they're communicating with one another, and that they're communicating with the patient? And so this is a big piece that we need to focus on, particularly when it comes to chronic disease management, because there is so much data that's generated. How do we manage it all in a way that it doesn't slip through the crack and that we're communicating with one another? So that's where we really focus on, as I said, care coordination and care management. I wanted to draw your attention to a resource. It's called the Safety Net Medical Home Initiative, and this was a demonstration project. It was a 5-year project that took 65 safety net health centers, not all of them were public housing, and they looked at practice transformation in becoming patient-centered medical homes. And they came up with these 8 transformation concepts, and each concept has its own implementation guide. And again, this will be on the Patient-Centered Medical Home resource catalog that's on the public housing website. That these guides are really helpful and walk you through the different processes needed to help you move towards patient-centered medical home recognition. And I just wanted to talk a little bit about empanelment, because that one is definitely a shift in the way we've used to always provide health care. And empanelment really means that you have an explicit, defined link between the patient and the provider care team. So as I said earlier, you make a point in your organization to organize your care and your workflow that each provider team, so whether it's your physician with a nurse practitioner and the social worker and the behavioral health therapist and the community health worker and the outreach worker, all work on a team, and they're assigned maybe a panel of 500 patients, and those patients always see that team. And some organizations name the team. I'm on the green team, I'm on the A team. So if the patient calls and wants to be seen and they say, well, I'm on the green team, they say, oh, well, that's with Dr. Smith and the nurse practitioner, Anna. We'll make sure that we schedule you with that team. Again, it's a way of keeping continuity of care. It's also a way of building up that patient's home. It's like they come to visit their own family. And so empanelment, there's certain ways that you can define a team and how you can calculate people, how many people can be on a provider team's panel, and there's lots of recommendations in the implementation guides. So I'm not going to go into detail on that because you can look that up. But it is, the Safety Net Medical Home Initiative is a really wonderful resource. They have great webinars about their implementation guides that can walk you through what does empanelment mean, what does team-based care mean, what does healing relationships mean. So, but I just wanted to speak specifically about empanelment because that's a new phrase that's not traditional in care. So we're going to talk a little bit about how can we use technology, how we can use health information technology to support the patient-centered medical home and to support quality improvement. And so when we talk about using technology for quality and safety, as I mentioned before, do you use evidence-based guidelines in your practice? If you have an electronic health record, do you use the clinical decision support within the EHR? What does that mean? It means that many of the EHR programs can prompt a user that this patient is due for a mammogram. They're over 40, they haven't had a mammogram, it can prompt these immunizations are due at the end of the visit. Based on clinical decision support can be based on risk factors. So if this person has risk factors for heart disease, it can walk you through the Framingham Heart Disease Risk Factor Scale. There's asthma clinical decision support. I'll be talking specifically about asthma clinical decision support tools in the electronic health record tomorrow. And do you use quality measurement to track adherence? So how do you use your electronic health record to recall patients who haven't followed up yet with their referral? How do you track lab tests to make sure that those lab results have come back and you've notified the patient and you've acted upon it? You can use the electronic health records to help you with that. How do you use the electronic health record and technology to engage patients and families? Do you use texting? Do you have texting where you can text your patient's prompts? Did you check your blood sugar today? There are some wonderful Text for Health programs that, there's a great one out of HRSA called Text for Baby for women who are pregnant and need prenatal care, and it's texting prompts. Did you take your prenatal vitamin today? How are you feeling today? Did you come in for your prenatal visit? Are you using technology to prompt patients? The majority of patients now have cell phones. More people have cell phones than landlines anymore. And in fact, most low-income, high-risk vulnerable patients are the highest users of cell phones. And so how do you use the technology to keep the patient engaged and connected to them? And how do you use health information technology to improve population and public health? And we talked about that earlier. Do you have registries? Can you call up your whole population of your asthma patients and do targeted education, or pull them all in for a week in October for its flu vaccine week and its asthma week, and you're going to call all your asthma patients and say, we're going to schedule visits for you the week of October so we can get you tuned up and ready for the winter. I'm stuck. No, I got it. Whoop. Yeah, they are. I know. Oh, I'll use that instead. That's good. So I'm going to talk a little bit about meaningful use of electronic health records and patient medical home, because I told you they're very closely aligned. And if you're just beginning the journey on the patient-centered medical home and you don't have any technology, you don't have an electronic medical record, testing for meaningful use of an electronic health record can help you jumpstart patient-centered medical home. What does that mean? Meaningful use, if you acquire or upgrade and adopt an electronic health record, you can attest to CMS for I'd recommend Medicaid, because we have a larger Medicaid population than Medicare population, and the incentive fundings are larger, to help you jumpstart with patient-centered medical home. If you are patient-centered medical home designated, but you don't have all the technology in place to support your medical home, a meaningful use can help with that. And meaningful use can also help investigate when you get that funding, how to use technology to improve your medical home and to improve your care. And I'm going to show you specifically how that works. So what is meaningful about meaningful use? You might hear the term meaningful use, and it sort of sounds like just jargon. And simply put, meaningful use means providers need to show that they're using a certified electronic health record in ways that can be measured significantly in quantity and quality. So using electronic health record that's been certified, and not just using it to capture data and capture your patient's record, but also use it to improve the quality and safety of your patient care. And so meaningful use is an umbrella term really for rules and regulations for both hospitals and eligible providers to qualify for federal incentive funds, as I mentioned, under the American Recovery and Reinvestment Act, or the ARA Act. And the incentive programs don't necessarily just focus on the adoption of health IT, but also how it can be used to not only capture data, but share it, meaning exchange it between your health center and your specialist, your hospital, and then to improve the care that you're providing. You need to be an eligible provider, and there's very specific regulations about that. Again, I will refer you to the Meaningful Use Resource Catalog that's on the public housing website, and it lists on the CMS website what you need to be an eligible provider. It's medical physicians, it's nurse practitioners. You need to see at least 30% of your patients have to be Medicaid or Medicaid and free care. And there are other criteria that you can refer to determine how many of the care providers in your health center can be eligible for these incentive funding. But when we talk about health information technology, we're really talking about not just electronic health records, the EHRs, but also health information exchange. Are you able to electronically exchange information from the hospital, the emergency room, the cardiologist, back to your health center? How are you sharing information? It used to be you might fax records, or you wait for them to come in the mail, that radiology report that might get mailed. But are you able to exchange that information electronically so that each organization can have that information at the point of care with immediate access? So when the patient is in front of them, they can pull it up and say, I see you were in the emergency room last night, and this is what they did. PHR means a personal health record, and you're going to hear more and more about this as we talk about patient engagement and consumer engagement and getting patients involved in being in the center of their care. Are they keeping their own records? And it used to be that patients just depended on the health center to have all their records. But to engage our patients, we're asking that they be a partner and they keep their records. And some of that is related to us sharing records and being more open with what happens during that visit. So we provide them with what's called an after-visit summary that summarizes the medications they're on, what their diagnosis list is, what their pharmacy number is, when they're due for a follow-up. And that information should be given to a patient after every visit. And it can be given in patient form, and that is required to meet your meaningful use measures. But it should also be available in a secure website where a patient can access it, called a patient portal, and they can keep their own record, where they can log in to a website, whether they have access at the health center in a computer kiosk or whether they go to the library and they have a secure password and the website, and they can get on and log in and say, I want to check out, I don't remember exactly what they told me about that last visit, what the side effects are of that medication. So I'm going to log into my personal health record and I'm going to look up my medication, or I'm going to look up my diagnosis because I need a little more information on that. And in the personal health record, there should be links to information, say a site like Medline Plus, where they can find information about their high blood pressure or exercises for their low back pain. There also should be links for things like housing services or the medical legal partnership if they need legal services to support their care. So people, get ready. This is not going away. We are moving towards using technology and integrating technology in electronic medical records, and that this is not the wave of the future, but this is now. And at this point, we have about 40% of physicians and 27% of hospitals, according to the January 2013 Health Affairs article, that are currently using electronic health records. The Meaningful Use Incentive funding that's available, and it's available up until 2021, has helped springboard health centers to adopt electronic health records. And as of 2015, health centers who don't have electronic health records and treat Medicare patients are going to get less reimbursement for not having electronic health records. So you can no longer kind of drag your feet and say, well, I'll do it later, or it's too complex, or I'm too small of a health center, I don't have the funding. That this is you got to get on the train or you're going to miss it. And so there are certainly some usability barriers, particularly when we're talking about health centers in safety net communities. One, I would say current vendor systems, and when I talk about vendor systems, I mean the electronic health record systems, whether you've heard of NextGen or GE, Success EHS is one of them out there, that they haven't quite yet really gotten, I'm trying to say this in a way that they haven't really included thought in addressing the needs specific to the safety net and including some of the things that are important to us and to our patients. And so one of the challenges often in health centers in public housing or homeless or migrant clinicians is that our staffing is pretty thin. We don't have a huge resource of staffing, and so many health centers don't particularly have an information technology department or experts. And so often it's maybe the office manager or the patient navigator who has an interest in technology who suddenly gets thrown in as the project manager for the electronic health record. And so we need more support and resources, and we need a more user-friendly system so that we don't have to slog through, a 100-page user manual online to figure out how to do this report or how to capture this data or how to reconfigure this form so we can capture housing status of our patients, or we can develop a clinical decision support for our patients. And the other thing is that vendors haven't really engaged clinicians or patients so much in what they want out of their electronic health record. And so they haven't really necessarily designed it with clinician and patient focus. So I think more will come, but now we have a lot of health centers and providers who are really frustrated with a system that's less than perfect. So in order to move towards adopting electronic health records and patient-centered medical home recognition, the number one thing you need is engaged leadership. Because if your leadership is not on board, then these initiatives are going to fall flat, because it requires more time, it requires more staffing, it really requires practice transformation, and you can't practice status quo and expect to accomplish this recognition process and to adopt health information technology. So leaders really dictate the attitude of the practice, and their job is to provide opportunities for staff to work at their highest license capability, so that perhaps medical assistants who maybe only used to bring patients back and do vitals, we're not really maximizing all their training and their usefulness, and maybe we need to really allow them to practice at a broader level so that then the nurse can practice at a broader level, and then the physician or nurse practitioner can practice at a broader level. Leaders need to work in the trenches. They need to get in and be a part of these meetings and these strategize the strategy, and they have to commit to the budget which will support these initiatives. I wanted to show you when you are transforming a practice. This slide I borrowed actually from Qualis Health, who were part of the Safety Net Medical Home Initiative. that when you're transforming any initiative in a practice, that there is a foundation that needs to be laid. And the first thing, as I mentioned, was engaged leadership, which is a human activity. It doesn't really require any technology. And having a commitment to an overall quality improvement strategy. We want to improve the quality and safety of our patients. We are committed to that. Now we really need to think about how we're going to do that. So the next step would be empanelment, as I mentioned, is creating healthcare teams that assign patient to a particular team so that that team is solely responsible for the care coordination, the care management of that patient. And fostering team-based relationships. It's no longer that the physician dictates how practice is done. It's the entire team that meets for maybe a 10-minute huddle every morning and say, this is who was on our schedule, and Mr. Smith has had some significant challenges. He lost his job. He hasn't been able to access his medication. His blood pressure is through the roof. We need to pull in the patient navigator to help with the patient assistance program. It is a team huddle to really talk about how are we going to manage these patients as a team. Again, requires maybe a little bit of technology, but not a whole lot of investment in technology. And then as you move up to the top layer, this is where you really can start using the technology to support your processes of care. Patient-centered interaction, as I said, engaging patients with the patient portal and personal health records, texting, using that to engage your patients, organized evidence-based care, implementing clinical decision support in your practice so that you are following protocols, making sure that everybody is being treated in the same way and you're using evidence-based practice. Enhancing access to care, thinking about maybe we need to change our scheduling. Rather than having a walk-in clinic where people walk in and can wait for 3 hours, maybe we need to do open access scheduling, or at least partial open access scheduling. Maybe we need to open up on a Saturday or several evenings because we have a large proportion of our patients who are working and don't finish their day until 6 p.m. and can't get to the clinic. And so they're using urgent centers or ED, the emergency department, rather than coming to us. And really focusing on redesigning your practice for care coordination. So strategic planning, we think about why. So engaged leadership, talking about we want to improve the quality of care we provide. We want to make our patients safer. What are we going to do about it? We're going to change the way we practice. We are going to become a patient-centered medical home. We are going to follow these 6 standards of care. Then how are we going to do it? Oftentimes, people, when you start to think about practice transformation, they get so mired in the, how in the world are we going to accomplish this? This is so much time and energy, and we don't have the money or the resources, that they forget that the most important thing is to think about the why, then the what, then you strategize on the how. So alignment with your organizational priorities is a really great place to start. And I apologize that these screens are so far away and the print is really tiny. But what I was trying to show you, and I borrowed this from the University of North Carolina's Medical Center, is what they did as an organization is they decided that they wanted to improve quality and safety in their healthcare system. And so they said, we're going to do that by becoming patient-centered medical home, and we're going to adopt an electronic medical record and try and attest to meaningful use so we can get the incentive funding, and we know that that's going to improve the quality of our care. At the same time, they were also doing joint commission, and they were looking at clinical quality measures through PQRI. So what they did was they aligned all the different priorities, and then they highlighted which ones match. So it's sort of like, okay, which ones should we really focus on that can hit all 4 of our strategies at once? And then they worked their way down. And this is a really helpful way to start strategizing with practice transformation is make sure you don't triple your work. Because as I mentioned before, meaningful use, if you achieve meaningful use, you're 50% of the way to patient-centered medical home recognition. So you can do both at the same time. Just make sure that you align what you're doing with each measure. So as you click off access on patient-centered medical home, you've clicked off all of the core requirements for meaningful use. And then you move along that way. That's called process development. So analyze your workflow. what is your current workflow? And when I finish talking with these slides and allow for questions, I actually have some exercises, and I'm going to have you work together at tables with analyzing your current health center workflow. And that will give you an idea of what that process is like. What are you currently doing? Where do you want to get to? How do you think you're going to get there? Develop team-based care model. As I said, once you move to a team-based care, it's easier to start focusing. You have many more resources. There's power in numbers. Implement clinical decision support. Think about your patients. What are some of the things? For example, when we took care of our diabetes patients, we realized that we were really bad at making sure that our patients with diabetes had gotten podiatry exams. And so we needed to figure out, and we knew that the recommendations were that diabetic patients should have an annual foot exam. So we strategized with our team and our operational workflow, how are we going to make sure that we captured our diabetic patients and made sure that we got, that they had a foot exam done and documented on their chart every year. Care coordination and management, and health information exchange strategy. How are you going to share information between organizations so that patients don't fall through the crack? You don't duplicate services and blood tests, or you don't mismanage medications because they come out of the hospital with 6 new medications and you're still prescribing your old medications, and then you have problem with medication side effects, or even worse, rehospitalization due to complications from medication mismanagement. So anyone see Jerry Maguire? Anyone remember that movie? Show me the money, right? So this practice transformation ain't cheap. It costs money. It costs money because you have more resources, more time, you have more meetings where you have to strategize, do process improvement. That means you're not necessarily seeing patients during that time, and when you see patients, that's when you generate revenue. So how are you going to do this? Show me the money. Well, that's where the meaningful use incentives come in. So through CMS, if you apply for the meaningful use incentives, there is a fair amount of money that's available for you to help pay for this transformation. How much are they? Well, if you began with adopting your electronic health record in 2011, you could attest and receive $21,250 per eligible provider. So for every eligible provider in your health center, say you have 5, then 5 times $21,250. And then in the subsequent years, you could get the same amount of money as long as you were meeting those standards every year. And you are eligible up to a total of $63,750. Now, it's not like you can just apply and get it. You have to demonstrate that you are meeting the measurements in order to qualify for that. And again, these transformation processes are expensive. $63,750 sounds like a lot of money, but it's not enough money to cover an electronic medical record and all the hardware, the software, the upkeep, maybe having to hire an IT specialist who manages all the programs and the upgrades. But it's a start. In the first year, you only have to demonstrate that you meet meaningful use measures for 90 days in a row. You do reporting, and then you can report it, or what they call attest, to CMS, and then they cut a check, and there you go. Subsequent years, you have to continue that for the full 12 months, except for 2014, because they are upgrading the certification standards for electronic health records. You may need to upgrade your system, and if that's the case, then they are giving people leeway to only have to attest for 90 days in a row. So this is just a chart, again, much more detail at the CMS website and on the Meaningful Use resource catalog that I mentioned. The next step is, as I mentioned, many health centers don't necessarily have a quality improvement committee or have information technology staff. You have to build a committee. This is a committee that requires information technology. It requires a focus on quality improvement. This is where leadership steps in, and they must support time away from patient care so that this committee can meet and strategize weekly And I would recommend that that committee has representatives from the clinical realm, from the operational side, and from the IT side, so you can speak to all areas of the project. The IT department needs to really help support this, because with quality improvement, you need IT to make sure that, I mean, it's great to have an electronic health record, but if the system goes down, the server's not available, hardware breaks, if you can't do any reporting because the reporting software is not working, so it's really important that you prioritize in your budget that you have IT available to support these initiatives. Don't forget about communication. You can't decide as an organization that you are going to transform practice and then not talk to the people who are working in the organization about it. You need to inform them weekly what you are doing. And I'll tell you an example of poor communication, and it goes back to the podiatry exam with our diabetic patients, is that we had in a health center that I once worked in, we had a QI committee who decided that we were going to work on our diabetic patients and make sure we met all the guidelines, and we were really poor at getting foot exams. So they decided in their meeting that every time any patient came in who had diabetes, regardless if they came in for a splinter in their finger or for a blood pressure check or for a rash or a cold, that they had to take off their shoes and socks and sit there in bare feet. But they failed to tell any of the physicians and nurse practitioners that this is what they expected. And so when I walked in to see a patient, they came in for a cold, and it was wintertime, and they had their shoes and socks off. And I said, and they were standing on a piece of paper. And I said, well, what is this? Why do you have your shoes and socks off? And they said, I don't know. And I said, well, I don't know either. And so then I had to go out and say, what is this? Well, the medical assistant said, well, we were told every patient who has diabetes on their chart has to take off their shoes and socks. But nobody explained that that was their way to prompt the clinicians, oh, you better look at their feet because they haven't had a foot exam. It was not a great execution of plan, but the biggest problem with that was the lack of communication. So communication has to be a key part of your strategy whenever you're trying to transform practice. You need to keep your staff engaged, whether you do that with weekly emails, sometimes screen servers on everybody's homepage. There can be like a big communication board, and or sometimes it can be signs on the bathroom door, signs in the lab. This is what we're going to focus on this week. Remember, making sure that you communicate it in your staff meetings if you have them. But communication has to be key, or else people end up feeling really confused and resentful that they're being told to do things without without anyone explaining to them why they're doing it. We talked about installing an IT strategy. This is particularly key in safety net practices, especially when we're talking about maybe health centers that are in old buildings that may not have good Wi-Fi or good connections. If you're on a mobile van or if you're doing any street outreach, we have to talk about security and privacy. If you're out using an iPad or a tablet wirelessly, is it secure? What do you do to make sure that you don't keep patient information on that tablet? Because if it's lost or not communicating patient information via unsecured text or email because of security and privacy issues. So you have to have a policy for your IT strategy. Can employees use smartphones? Do they need to use their own, or do they need to use the organization's? Can they use laptops at home? What is the strategy to make sure that patient information is kept private and secure? So this is a huge piece of adopting health information technology in your organization that's often neglected, and there are some software programs and some organizations that can help with privacy and security evaluations, but this cannot be neglected. Never underestimate the power of people, because it's not about the technology ultimately, it's about people and the people who will use it. So training is really important. And I think this is another area that's often neglected that needs to be supported by leadership, is there has to be a commitment to training, and not only initial training, but also continuous training. Is it a part of your annual review? Is it part of your staff meetings? Is it something that staff gets time off to train? Is there a training policy? Are there places where they can go to look up areas that they may have forgotten about? Also establish realistic goals. If you have front desk people who've never even touched a computer, they're not familiar even with general keyboarding, your expectation of how they're going to use technology has to be realistic, that they're going to require a little bit more training. And so really this has to be another piece of that planning and strategy when you talk about how you're going to do this, is really implementing a realistic, a robust training program. And patient engagement. As I mentioned in the beginning, and we're coming full circle, is that patients are the most underutilized part of the health system, right? So our health system was built around patients, and often we keep them out of it. We keep them out of the loop. We don't include them in the planning. We don't ask them what matters to them. So engaging our patients in care, in the transformation process, saying, we are building a patient-centered medical home. What does that mean? How do you feel about it? Do you like where you come? Do you like being assigned to a healthcare team? What kind of feedback can we get from you? Do you feel like we are accessible? What would help you come in to see us more easily? Is it access? Are our hours not convenient for you? Are we not providing you information? Just merely turning your computer screen so that when you sit and you talk to your patients, you show them what you're typing. I often sit with my patients, particularly my adolescent patients, as I ask them lots of private questions about sex and drugs and tobacco and alcohol, and I say, I want you to see what I'm writing, because this is your record. This is all about you, and you have every right to see what I'm putting down, and you have every right to correct what I put down if you don't like the way I say it or you don't understand the way I say it. Is pulling your patient into the care so that they feel more engaged, and if they're more engaged, they're more willing, they're more interested in taking care of themselves and participating. So ways to do that, besides just engaging them and showing them the computer, is showing them videos. We used to just hand out patient education material. What if they don't speak English or they have low health literacy? And you could have a PhD in engineering but still not understand what's written on a piece of paper about your cardiovascular disease. Are we being sensitive to the fact that patients may not understand what we provide for them? What if they don't have good vision or they're hearing impaired? Have we sent them to a website or provided videos that are in American Sign Language to explain to them what their heart disease is all about or what their medication is? There's a wonderful website called DeafMD, and that is filled with videos that explain healthcare processes in American Sign Language. So just having those resources at our fingertips. We talked about after-visit summaries, making sure that we provide patient with information about what happened that day. Many of them take it home, they put it on the refrigerator so they can refer back to it. Or they say, wait a minute, you said that my BMI is greater than 85%. What does that mean? That means I'm obese? And sometimes that's offensive to them, but when you explain that obesity is a medical term, it means it puts you at risk for other health related illnesses, then you've engaged them. And they may not like the diagnosis, but it may motivate them to lose some weight so that they can shift that BMI and maybe lose that diagnosis of obesity. So there are plenty of resources that can help you and your organization transform your practice. You don't have to do it alone. You have organizations like the National Center for Health and Public Housing, and you have Health Partners for Sustainability. You have Health Center Controlled Networks, which are HRSA-funded networks that will help with your IT project management, training and support, data management, meaningful use adoption. They will help you with medical home solutions. They are HRSA-funded so that they are not as costly as private consultants. So there are organizations that can help you with this transformation process because oftentimes you don't necessarily have the staff or the resources to do it alone. And again, these resources are listed on the resource catalogs that have been provided for the National Center, so I would refer you to them. And lastly, I just want to tell you, take a deep breath, that practice transformation really takes a lot of effort. It is not easy. It does require some discomfort because many of us do not like change, and particularly healthcare providers who have been doing things the same way for a long period of time. That adopting technology isn't just retrofitting an electronic health record into the way you already practice because it's just a fancy tool that won't really get used in the best way. It's really looking at how do we transform practice to improve quality, improve safety, engage the patient, and maybe we use some technology to help us support that. So that was a really broad brush overview of patient-centered medical home and meaningful use of health information technology. And I'd be happy to talk about some resources for more details. But what I'd like to do now is gather you. Maybe we can have, oh yeah, okay. Any questions? It was a lot of information, so. This is the part that's always when no one has any questions because it's way too much information to digest. Sometimes it's hard to think about what questions you may have. My plans are that I have some exercises about the patient-centered medical home standards, so care coordination, tracking, and referral follow-up and access. And what I'd like to do is gather, I have 4 different exercises, so if we could maybe consolidate some tables so we have 4 tables, and I'm going to give you each different exercises, and it's wonderful if you're a variety of, some people may be administrators, some people may be patients, some people may be social workers, behavioral health, and I'd like you to kind of talk about the process and provide some input about what you're currently doing or what you think you could do to meet some of these standards.
Did anyone have questions? Right over here.
So you mentioned for, so you mentioned for meaningful use that in 2014 there's going to be like some leeway due to upgrades. Could you kind of expand on what that is referring to?
So software vendors who make the electronic health record have to be certified to certain standards, that they'll meet certain standards. And those standards will shift and change in 2014. The standards have been upgraded. And so those who are currently on systems will, their vendors hopefully will automatically kind of upgrade the system for to meet those standards. And some people who have been on electronic health records for a very long time with older vendors, those vendors may not be able to meet those standards. So there's going to be this period of adjustment where practices may be using a vendor that is not up to that standard, and they either need to figure out with the vendor how the vendor is going to meet that standard, or they're going to need to make a decision to migrate from that one vendor to another vendor that's certified. And because there may be a lot of transitioning that happens in 2014, CMS has said it may be difficult to meet meaningful use standards for that entire period of time, so we'll just tell you you have to document 90 days in a row.
Other questions?
Thank you very much for your excellent presentation. But I'm curious as to know whether you have come across some of the challenges that providers are having in their effort to, fulfill those meaningful use measures.
Can you repeat I heard the thank you. That was nice.
What kind of challenges?
Challenges,
That
yes.
providers are.
Right. So this is where I said it's all about people. That there are certainly some providers who don't like technology and are really resistant, and some of them don't want to type. And sometimes it's a matter of finding the right technology to support their workflow. And so sometimes it's, instead of saying, well, you have to type on a keyboard, there is some dictation software, like Dragon software, where they can just dictate their note and it automatically is entered into the electronic health record. So that sometimes can be the challenge. I will say one of the greatest challenges, and I mentioned it, is that the software vendors have created or have built systems to capture data, but it's not necessarily usable. And so when we talk about usability, we think about, is it simple? Does it mirror the workflow of the way a provider usually examines a patient? So, does it work with the way that I would do a history and document information and do a physical exam? And will I find things in a way that I like? Is the font in a way that I can read it? Do I scroll left to right? Is it a big enough font? So some of that is vendor related, and that's where I said they really need to pull clinicians and patients in to provide feedback. There are some practices that have really struggled with adoption, and what I would suggest is finding a provider champion who says, so I'll use my own personal experience because I worked in a health center that was a relatively early adopter around 2005, 2006. And I went to Catholic school my whole life, so I have really neat handwriting. And it drove me crazy working with providers who had horrible handwriting and I couldn't understand their notes. And it made me uncomfortable. It made me nervous because if I had to take care of their patients, I couldn't understand what they were reading or I couldn't read their prescriptions. Again, another reason to stick with patient panels where they see the same provider over and over again. But initially one of the things I loved is that everybody's note looked the same. It was uniform, it was printed, you could read it. I like to cross my T's and dot my I's. The other thing about it for me was I liked that I knew where everything was. I knew I could find labs here, I knew I could find radiology here, I knew I had the problem list here. So from an organizational standpoint, I was a huge champion, and I could really talk it up. I could also understand the frustrations. It's a lot of clicking. It's a lot more typing. When you first learn as a clinician, you learn to sit with your patient, interview them, take a history, and then you stand and you do a physical exam. Then they leave, and then you document. And the longer you practice, I've been in practice a long time, you can take a history and examine patients at the same time, right? So as you're looking in their ear, you ask them about any ear complaints and so on and so forth. When you go back to an electronic health record, suddenly you have to go back to the old way, right? You sit down in front of the screen and you have to ask all the questions and do all the clicking, and then you do the exam. So sometimes it's a shift in the way you practice, and it's uncomfortable. We don't like change, but the practices that have done it the best and have really are those that have provider champions, a physician or nurse practitioner who can really champion the project and say, we can do this because it does help us with quality. It does help us with safety. You just need to have when we adopted our EHR early, it was when they took a diabetes drug off the market because of some really severe side effects. And it was wonderful because what we could say is, we have 10,000 patients, and how in the world would we ever identify all of our diabetic patients and all of our diabetic patients who are on this particular medication had we not had the electronic health record? That would have been hours and hours of pulling every chart off the shelf. So it's having someone reframe it and saying, yes, I know this changes the way you work. Yes, I know it's a little uncomfortable. Maybe you do better with a laptop instead of a standard computer. Maybe you want to use an iPad so you can work with the actual hardware to make the provider and the team more comfortable. Maybe you want to use a rolling cart so you don't have to carry it. So you try and find ways that makes it a little bit more comfortable for them, but then you have that champion who says, it's that whole, why are we doing this? You have to always go back to the why. We want to improve quality and safety of our patients, and this is a tool that helps us do that.
Any other questions? Anyone who's not a provider have experience with a health center and an electronic health record? Want to share your experience on how it's been for you as the consumer, the person receiving healthcare, to be receiving it through an electronic health record? Anyone? Okay, I think you want to go to your exercise?
Okay.
Okay.
So this is the part where I'm asking you to be engaged, like engaged consumers, right? So sometimes you go to sessions and you're like, oh, I just wanted to sit there and listen, but I'm going to ask you to get engaged because these exercises will help you think of things to bring back to your health center, whether you're a consumer or you work in a health center. So I'm going to ask if we could kind of consolidate tables here. And so everybody has exercises. So you can cut me off recording because you're not going to be able to hear me after this.